Okay, so this is the second part of Unit 5 for Pharmacology. We will be going over Chapter 20, Drugs for Degenerative Diseases of the Nervous System. And lastly, Chapter 21 that will be included, Drugs for the Neuromuscular Disorders. So let's go ahead and get started. So talking about degenerative diseases of the nervous system, there are a few main diseases that we are going to talk about. The first one is Parkinson's. The second one is Alzheimer's. And the third one is multiple sclerosis. So Parkinson's disease, it affects the central nervous system. And what it does is there is a progressive loss of dopamine. Symptoms of this include tremors. You'll see them mostly in their hands. Also muscle rigidity, bradykinesia, which is just slow movement. Also postural instability and affective flattening. This is when their behavior seems very flat. They don't show much emotion. You'll see when they walk that a lot of patients that have Parkinson's disease, they walk with a shuffling gait. They shuffle their feet. They don't really pick them up, but they shuffle them in small steps, so they are more at risk for falls. And I'm not sure if there's a reason why, but Parkinson's does affect more men than it does women. The second one is Alzheimer's, and this is the second most common degenerative disease of the central nervous system. It is progressive loss of brain function and includes memory loss, confusion, and dementia. But dementia is different than Alzheimer's. Dementia is kind of like an umbrella of a lot more memory disorders. So Alzheimer's is just under that umbrella of dementia. It does mainly affect people over the age of 50, but in today's society, it does even affect children and young to middle adults. So the age of Alzheimer's is decreasing. And the third is multiple sclerosis. This is an inflammatory disorder that causes damage to the myelin in the brain and spinal cord. It causes progressive weakness and also visual disturbances, mood alterations, and cognitive defects. A lot of times this does start in your young to middle adulthood and is characterized by remissions and exacerbations. So the patient that's diagnosed with MS, they may be stable for say 6 months to a year, but then may have an exacerbation where their symptoms, they become worse for a period of time. And they'll have to take higher doses of medicine or go through a different type of treatment to help them through that exacerbation. And when they come out of it, they might be a little bit more worse off, or they may go back to their normal functioning. But this does progress. There is really no coming back once you are diagnosed with multiple sclerosis. We just talked about our symptoms of Parkinson's.
Actually, yeah, you did.
This disease primarily affects muscle movement, just like I said. And also those tremors, those can also affect not only their hands, but also their lower limbs also. They also may experience anxiety or depression, obviously, because if they may lose their independence because they now have less control over their body. Because a lot of times they still, unless they do get dementia, they're still in their right mind and still alert, but they're just losing that control over their body. They may have sleep disturbances. Some patients do decline into dementia. And then also autonomic nervous system disturbances. And these are caused by degeneration of the dopamine producing neurons that are in the central nervous system. The substantia nigra portion of the brain, this is just where that degeneration occurs. And because of that degeneration, that is why the corpus striatum is affected. Because the corpus striatum, this is the region of the brain that controls your unconscious muscle movements. So basically kind of like your autonomic nervous system, this is what's affected. So dopamine and acetylcholine are both neurotransmitters that are affected, and they affect the balance and posture. That's why they do become fall risks. Also, their muscle tone. That's where you get the bradykinesia from. It's harder for them to initiate movements, and so those movements may seem smaller, whether it be from walking to picking up objects to even chewing food. Everything is a lot harder for them. So kind of a way you might be able to think about that is if you take like this power steering out of the car, how like you can barely even turn the wheel after that. That would kind of be how it would be if you took the dopamine and acetylcholine out of your corpus striatum. In the goal of drug therapy, we want to restore our dopamine function back to our patients. We want to block the acetylcholine and avoid extra pyramidal effects. What we would like to see from our patients is for them to be able to perform their ADLs again, whether it be from walking to eating to dressing, also bathing, those daily activities, enhancing them back to where they previously were before as much as we can. That would be the goal for drug therapy. It will be important to remember that when you take anti-Parkinson drugs for a long period of time, there may be a time where the drug loses its effect, kind of like the patient builds a tolerance to it. And this is called the wearing off effect. Symptoms during this time will seem worse for the patient, so they may have worse tremors, they may have more difficulty walking, more episodes of incontinence, things of that nature. So that would be something to look for while patients are getting therapy for Parkinsonism. So that might be something you may want to report to the doctor if you do see that happen, and notice that they have been on the same dose for some time now. For our anti-Parkinson agents, they are going to work to restore balance of dopamine and also acetylcholine in the brain. These are called our dopaminergic adjunct drugs. And then we also may use anticholinergics, so our cholinergic blockers. And thinking back to chapter 12 about our cholinergic drugs, the anticholinergics, those are going to inhibit the parasympathetic nervous system. So by inhibiting the parasympathetic, the sympathetic is going to be enhanced. So that means that fight or flight symptoms at that time will be enhanced for the patient. And these are a list of our drugs for Parkinson's. Our prototype is levodopa-carbidopa. You will see this a lot in the nursing home and also in the hospital. For our dopamine agonists, some adverse effects that you may see with these, you might see skin irritation. The patient may also have difficulty concentrating, confusion, orthostatic hypotension. Parkinson's patients are already at risk for falls because of their shuffling gait and the bradykinesia. Adding on the orthostatic hypotension, they'll definitely need to be assessed regularly and making sure that fall precautions are put in place for them. They are at increased risk for acute myocardial infarctions or heart attacks, also shock. Labs to look for them will be liver failure, so you want to check their LFTs, their liver function tests, and they may also hallucinate. And this is our prototype that I told you about, the levodopa, carbidopa, entacapone. So that's 3 drugs in one for Parkinson's. And this is going to increase the biosynthesis of dopamine. This drug is contraindicated in narrow angle glaucoma. It may cause involuntary movements. So safety is big with this. And here are all the slides that you need for your drug cards. This drug needs to be discontinued gradually because it can cause Parkinson-like symptoms if it is stopped right away. And also psychosis may develop. It interacts with many drugs, so please be aware of these. These are just a few more examples of drugs that come from Parkinson's. These are our dopaminergic adjunct agents. And what the catechol or methyltransferase does, this reduces the requirement for the levodopa carbidopa. Because as you could see, even though it's good for Parkinson's as a whole, it does create a lot of side effects. There are a lot of contraindications. There are a lot of effects it can have on your body concerning your liver, concerning your kidneys. So if you can decrease the amount needed by bringing something else on board to help, that's what COMT is for. And our anticholinergic agents. These block acetylcholine. They inhibit overactivity in the brain. They are not as effective as the other drugs, so they are used in the early stages of Parkinson's disease. So hopefully it will be able to kind of slow it down to where they don't need those heavier drugs that cause more side effects. And these are examples of our drugs: cogentin, aconitine, and also Artane. And our prototype is cogentin. This blocks excess cholinergic stimulation of neurons at the corpus striatum, so it inhibits that overactivity in the brain that causes the extra involuntary movements such as the tremors and things like that. side effects that you may get from this are sedation, nausea, constipation, drowsiness, also again hypotension, so fall risks will still be a problem. Paralytic ileus, this is something that is very serious. That's when you have a complete obstruction somewhere in your intestine, and most of the time you do have to get this removed surgically. So that's why checking bowel sounds will be important for patients that are taking anticholinergics, because if the sympathetic nervous system is activated, fight or flight, our GI tract is going to be shut down. So if the GI tract's not going to be moving and have that motility, paralytic ileus is going to have a chance to occur, because that bowel is just going to be sitting there. So that's where you need to check each quadrant and note that if you don't hear sounds, note where you stop hearing them. So that way the doctor or whoever is doing imaging will know where to look for the ileus at. Cardiovascular collapse, loss of balance, like we said, from the hypotension, also from the effects of the Parkinson's, and hallucinations. This medication is able to suppress the tremors. So the small movements in their hands, the tremors that they have, it is effective at suppressing this to hopefully give them more mobility back to their hands and their legs, but is not effective at relieving the dyskinesia. So they will have those slow, hard movements where they are slower, where eating will take longer, chewing will be harder for them. Here are all the slides that you need for your drug cards. So blockage of our urinary tract, if you have severe constipation, those will be contraindicated because our sympathetic nervous system will be activated. Still a lot of drug interactions. No over-the-counter cold medicines. So for patient teaching, you will want to teach them to increase their fiber and also their fluids. This will help to maintain their output, making sure that they're still having bowel movements, making sure they are still having urinary output. So since those two places will be affected. By avoiding the pyridosine, what this does is it decreases the effects of the levodopa that will be in your blood system if you take them both together. So that's why it's important for your patients not to be taking the pyridosine and also the dopaminergic drugs together. So it will be important to do a drug reconciliation before starting them on these type of drugs. It may take several months to take full effect. So that will be something to teach your patient about if they, to avoid them becoming upset in the beginning, saying their medication's not working. Just let them know that it does take time. So they will have to be patient, and they do need to be weaned off these drugs, so they cannot abruptly stop them. Encourage fluids for these patients. That's to help relieve their dry mouth from the effects of the sympathetic nervous system being stimulated. Avoid alcohol, Avoid bright sunlight or wear glasses. And moving on to Alzheimer's. This is responsible for 70% of all dementia. This is categorized as progressive loss of brain function. So over time, the person will lose memory, will have memory loss, they'll have confusion. It will affect their memory, their cognitive function, and their behavior. So it can affect their walking over time, where they'll forget how to walk. It can affect eating, where they'll eventually forget how to eat. It can even affect speech for some people, where they forget how to speak. So Alzheimer's can affect all ways of functioning. There really is no pinpoint cause for Alzheimer's, but it can be possibly related to genetics if there is chronic inflammation. Environmental factors can be it, immunologic factors, nutritional. I have read that I believe if you lack vitamin D, they said that you are at risk for Alzheimer's or dementia. And then viruses. Symptoms of AD include impaired memory or judgment, confusion and disorientation, inability to recognize family and friends. For patients that have Alzheimer's, this is usually something that goes after a long time, the inability to recognize family and friends. Because for the most part, their long-term memory stays intact better than their short-term. So when they're in the beginning stages, they might not remember what they ate last night for dinner, or they might not remember where they went on vacation last year, but they'll remember what happened back in 1975. They may have aggressive behavior, depression, paranoia, definitely, because you're going to be anxious from not knowing what's going on, especially if you wake up and don't know where you're at, and also anxiety. And the goal of Alzheimer's disease for pharmacotherapy is not to treat it, but just to slow the memory loss and also the symptoms. If you do catch it early on, you can be able to improve activities of daily living, also behavior and cognition. Like I said, there is no cure for Alzheimer's. And once you get into the late stages of the disease, then medications, they are not effective. So our first class are cholinesterase inhibitors. These prevent the breakdown of acetylcholine in the brain, which enhances the transmission of our cholinergic neurons. This works by slowing the progression of AD. Examples of this will be donepezil, galantamine, and also rivastigmine. Rivastigmine, the Exelon, I know when I would give that, it would usually be the patch, and you would change it every 24 hours. Aricept, I would give PO, and I've never worked with galantamine. And usually Aricept is given at night. And our prototype is that donepezil, Aricept. It can cause headaches, dizziness, or insomnia, renal toxicity. So their renal functions will need to be evaluated regularly. Bradycardia or heart block, so they will need a good cardiovascular assessment when you do your assessments for these patients if they're taking one of these drugs. And also extreme weight loss. Patients with these drugs definitely are irritable. That would probably be one of the best things about giving it at nighttime. Hopefully you can give it to them at night and then they go to bed for the night. Or they may be up walking and pacing the hallway. But it is only used for mild to moderate Alzheimer's. And it does need to be given on a regular schedule in order for it to be effective. And that can be difficult with your Alzheimer's patients, especially if they are paranoid or just don't want to take their medicine. Staying regular might be a challenge. For patients that have bradycardia, hypotension, asthma, and also hyperthyroidism or peptic ulcers, they need to be monitored carefully. And it will be contraindicated in patients with GI bleeding and also jaundice, so impaired liver functioning. Another drug is Namenda. And Namenda, this one is usually given twice a day. The Aricept is given once a day, but these drugs were made to work together. So sometimes you will see patients that are only prescribed Namenda or only prescribed the Nepazil Aricept. It's not really a call to the doctor that's needed. But I would just, if you're working in long-term care, I would just watch them over time to see if their behaviors do start to get better. And if not, then I would maybe call a doctor and recommend it. Because some doctors don't know that, especially if they're just regular PCPs and not gerontologists. But Namenda and Aricept were made to be given together in order to be most effective. And these adjunct medications, your atypical antipsychotic agents, the anxiolytics, the mood stabilizers, they may be given regularly or they may be given PRN. You may have Ativan, maybe Haldol. Sometimes we would use Depakote regularly for mood stabilizer. And that's just because, like we said, when you're on these other medications, you can have hallucinations, you can have psychosis with dementia. And so, especially if they have, Alzheimer's, if they have Alzheimer's and they're sundowning, that can sometimes be a bad picture. So having these adjunct medications definitely help to keep their mood stabilized, keep them safe, and keep everyone around them safe. For cholinesterase inhibitors, for nursing considerations, you do need to make sure you have their baseline vital signs because it can cause that bradycardia. It can cause their hypertension. You'll also want to monitor for changes in their mental status or mood, and then also dizziness, insomnia, and anorexia, because these can cause changes in your appetite leading to weight loss. So for the cholinesterase inhibitors, patient teaching or caregiver teaching, depending on how well the patient is able to receive their teaching or remember it. Take your medicine with food or milk to avoid GI upset. Also, make sure that you take these medications as prescribed. Try and stay regular with them, like we said. And teach us signs for overdose. These are the severe nausea and vomiting, sweating, salivation, hypertension, bradycardia, convulsions, or muscle weakness. That muscle weakness can include respiratory muscles, so you might see respiratory suppression, and it can be reversed with atropine. And the last one here is multiple sclerosis. The etiology is not known. There is no cure. Genetic, there can be genetic or microbial factors, and then also pathogens. I know that my aunt, she was just diagnosed with MS this past year, and they have no idea why she was why she got it. No one in our family's ever had MS, and they just don't know. So you can get MS, and there be no cause for it. And what happens when you have MS, the myelin sheath that are around your neurons, this basically is destroyed. So your neurons are demyelinized, and the destruction of the axon impairs ability of nerves to conduct electrical impulses, so they're not able to speak to each other like they once did. This causes inflammation and then also plaque buildup. Signs and symptoms of MS will include fatigue, heat sensitivity, neuropathic pain, impaired cognitive ability, disruption of balance and coordination, visual impairment, slurred speech, sexual dysfunction, bowel and bladder symptoms, also dizziness and vertigo. And like I said way in the beginning, you can go through periods of remission and exacerbation. So there may be times where these signs and symptoms are very low or even non-existent, and then you go through an exacerbation and certain symptoms may be heightened at that point. And there are no drugs really to remember for multiple sclerosis, because there is no cure. Really what you're trying to do is lengthen the time between exacerbations, and just to keep symptoms at a minimal and keep the patient as active as you can and as independent for as long as you can. So really just know the background of multiple sclerosis. And moving on to chapter 22, we have drugs for the neuromuscular disorders. So talking about muscle movement, this is dependent on our body systems, and not just our skeletal, but also our nervous system. Our brain has to send the impulses to whatever muscle and bone that needs to be moved. Also the muscular system. The endocrine system, because hormones do play a part in how strong your muscles are. If you're lacking in certain hormones, this can cause muscle weakness. So muscle movement depends on your hormones. And then obviously the skeletal system, because they are our structure. They are what's going to hold, they're kind of like what holds the structure of our body together so that we can have muscle movement. And know these three electrolytes: sodium, potassium, calcium. This is what determines how well able our muscles, bones, and joints are able to function. Sodium, potassium, and calcium. They need to be within normal ranges. You do not need to know those ranges yet. That will come in Med-Surg. But just remember, these three, they are electrolytes: sodium, potassium, and calcium. So talking about spasms, or muscle spasms in particular, this is involuntary movement of your muscle. And when you have just a single prolonged contraction, an example would be a Charlie horse. Like when your calf muscle just tightens and stay there, that's a tonic spasm. And then if you have a rapidly repeated contraction that's coming, going, coming, going, coming, going, that's where you have a clonic spasm. How you guys are saying like your eye twitches, that'd be clonic. So tonic spasm, that's a Charlie horse. Clonic spasm, that would be when your eye starts twitching. In spasms, they can cause diminished level of functioning. Causes of muscle spasms: it can be excessive use or also injury to your skeletal muscle. Could be from over medication, epilepsy if you do have a history of recurrent seizures, hypocalcemia, which is low calcium, if you're dehydrated, and then also neurological disorders. So non-pharmacologic treatment of muscle spasms, if they are not too serious, you may just be able to use immobilization. Applying heat or cold, that can sometimes help the muscles relax. Hydrotherapy, which is water therapy. Ultrasound. I actually had this done on my hip in high school. I fell and hurt my hip, and I was going through physical therapy, and then at the end they would always just use a regular ultrasound that you would use for babies, and they would just rub it around on my hip for about 10 to 15 minutes. And they just said something happens with the radio waves where ultrasound just kind of helps those tissues just relax and be able to heal better. Supervised exercise, which may be physical therapy or under the supervision of like a trainer. Massage and also manipulation. Stretching, repetitive movements, and in extreme cases you may have surgery. Pharmacologic treatment of our muscle spasms. You can use analgesics, especially if it's causing pain, if you do have a Charlie horse. Anti-inflammatory agents, and then also muscle relaxants. And our goal of muscle relaxants is to minimize pain and discomfort, increase range of motion, and also improve the ability to function independently. Muscle relaxants, they do have the tendency to make people sleepy when they do take them. So usually when you educate, if they can, wait until nighttime to take muscle relaxants, or if they take it during the day, at least don't drive or use heavy equipment. But you'll want to assess for drowsiness and dizziness in accordance to everything else that you do for meds, getting your health histories, doing your allergies, your interactions, also assessing vital signs and their LOA. Then also finding out about their pain. So you'll want to get their baseline pain before the muscle relaxant. Find out where it's at, how intense it is, what kind of spasm it is, and how long it's lasted. Does anything exacerbate it, such as movements, or do they just wake up with it? Finding out what exacerbates it is very important. Or does it happen like after going to the gym, to where you know they may be sweating and losing water, so it might be because of dehydration. So you might be able to piece it together through your assessment. And then you'll give the muscle relaxer, then continue to monitor pain, and then follow up on their pain after they've taken it to see how effective the medication has been. Muscle relaxants do have a tendency to cause slight withdrawal reactions. It's not as big as like narcotics, but you shouldn't just come off. If you've been taking them regularly, you should wean off of them, because your body does start to get a dependence for them. Also monitor for muscle tone, range of motion, and also degree of the muscle spasm, like I said. Unless there's contraindications, it is okay to use additional pain relief measures. Hopefully the patient will need just something light like an NSAID or Tylenol to help, to be an adjunct to the muscle relaxant. And then monitor for side effects. People that have liver disease, pulmonary, meaning your lungs, or cardiac, your heart dysfunction, should not take these drugs. Do not drink alcohol or take drugs while taking muscle relaxants, because those will depress your central nervous system even more. And do not abruptly stop taking muscle relaxants. It can result in seizures. Are centrally acting skeletal muscle relaxants. These are used to treat local spasms resulting from muscular injury. They inhibit motor neurons within the brain and spinal cord by depressing the CNS and altering spinal reflexes. So when you relax those muscles, obviously if they were tight before, you're going to decrease pain, and they're going to be able to move their muscle more, so increase range of motion. And it does have the potential to cause sedation. So that's why it should be taken at night, or at least don't drive during the day. And our prototype drug is cyclobenzaprine, which is Amycrex or Flexeril. It can cause anticholinergic effects. And this needs to be taken just short term. So up to only 2 to 3 weeks. This is not a drug that's meant to be taken long term. Angioedema can occur in these patients. One other place that you'll see angioedema more often is patients that take lisinopril. That's when they'll get that extreme swelling in their face, usually in their tongues, but it can occur also in their lips. And the thing with angioedema, if it does occur on your tongue can end up blocking your throat, putting you at risk of blocking your respiratory tract. In direct acting antispasmodics, This is used for muscle spasms that are associated with certain neurological disorders or motor damage, and it just suppresses the hyperactive reflexes that keep firing off, and it works by controlling calcium ions. Our prototype of this drug is Dantrium. The primary use is for dystonias and also leg cramps. And dystonia is just another name for repetitive muscle contractions or twisting movements. And it can be used after spinal cord injury, also stroke, CP, believe that's cerebral palsy, and then MS, multiple sclerosis. Or also heavy or muscle pain after heavy exercise. This is not preferred for our pregnant patients. Where it says IV solution has a high pH and therefore extremely irritating to the tissue, that just means if you give this drug straight into their IV without being, without putting like saline or something with it to help dilute it, that's what I'm looking for, dilute it, it's gonna burn. So you'll need to see what what filler you can use to dilute it with to make sure that it doesn't burn, and then it'll possibly need to be administered slowly so that way it doesn't cause that irritation to the tissue. Can cause tachycardia, that erratic blood pressure, so vital signs will need to be monitored, as well as urinary output. Hepatitis and liver failure, so getting their liver function test done. So assessment for these patients that will be taking or that have neuromuscular disorders. A complete health history. If they have any other medical conditions, family medical conditions, any illicit drug use, also smoking, alcohol use, any medications taking, over the counter, herbals, and also prescribed. Also their biographical data. Their physical assessment, where you will focus in on cardiac, also lungs. Okay, I can't remember where I was at. I had to pause because someone came in my office. But physical exam, making sure you do check lungs good, check cardiovascular system good, musculoskeletal, how we did in class the other day, where you're checking muscle strength, also their gait, and also again assessing where their spasms may be, and the intensity, the duration, the location, and what exacerbates it. That kind of goes along also with pain. Also getting their baseline vitals and lab results, and their level of consciousness, so seeing how alert and oriented they are. The goal of this therapy is to decrease the pain wherever they're having their spasms, increase their range of motion, reduce their spasms, hopefully have limited to minimal adverse effects, understand of drug regimen, and then understanding of proper self-administration. And that also includes when the drug will be stopped, how to properly stop the drug. Still going to monitor for a level of consciousness and vital signs, pain, their muscle tone, range of motion, and degree of their spasm. When you're doing the tone and range of motion, make sure you check like whatever side that is affected, check the opposite side so that way you have something to compare it to, like the normal. And then provide adjunct therapy. So if they're still having pain, they can probably still get something else as an adjunct to help decrease that pain. Says for bowel sounds, also urinary retention. The tongue and facial swelling, that's for the angioedema. And also educate the patient not to use any other central nervous system depressants while on the muscle relaxants.